respected medicos, practicing clinicians and surgeons, myself Dr. G.R. Patel, Professor and Head Department of Surgery, Government Medical College, Surat and Valsad. Today, we will be talking about certain statements made by the stalwarts and accepting them with great regards. Such statements are time-tested and save the surgeon as well as patients from agonizing procedures and expenses. Myself is having 28 years of teaching experience, and I have been examiner for MS for last 15 years. So today we'll be talking about those very important and very precious statements which I feel is everybody must know. Such statements are time tested and save the surgeon as well as patient from agonizing procedures and expenses. Certain practicing surgeons during their tenure have observed certain unique features which are constantly seen in a patient having a particular pathology. We call them $1,000,000 statement or rule of thumb or by tradition or by convention, etc. The findings are so constant and conspicuous that they can't be challenged. The, so I have got a collection of such statements which I am going to talk to you to mention those statements in front of you. The best way, the title is Surgery Pulse. The best way to diagnose shock is to suspect it, and the best way to treat the shock is to prevent it. This is a statement made by late Professor M. Thakkar of Medical College, Baroda. In short, the patient must not be allowed to lapse into shock. Shock must not develop at all. If the patient goes into shock, he might go into irreversible shock and then death. So shock is a very dangerous situation which every treating clinician must know. In a patient developing hypovolemic shock, tachycardia appears first, followed by fall in blood pressure. A rising pulse rate is an unequivocal sign of active bleeding, external or internal. A red diagnosis is rarely correct. Abbreviation must not be used in surgery. It may have double meaning, which can invite disaster. For example, MI means myocardial infarction or mitral incompetence. Then always write right instead of R in short and left instead of L. This is very important. This will avoid many uh, wrong side amputation, wrong side plaster, and wrong side treatment. So this is very important. One must write in full form RIGHT and left, not just short form L. Listen to the patient. He is telling you the diagnosis. Narrate the history in patient's own words. In a patient suspected to have acute appendicitis and is having normal or increased appetite, it is not a case of appendicitis. Revise the diagnosis. Tapping tenderness is a sure sign of peritonitis. For patients of acute intestinal obstruction under observation, act before the sun is set. Means act before the bowel becomes gangrenous or patient is dead. Obstruction must be relieved at the earliest by any means, usually by surgery. In a patient of intestinal obstruction, tenderness of the abdomen indicates ischemia and the bowel underneath. Operate immediately. Then a palpable tumor of pancreas is inoperable, so incurable. Examination of the back of the tongue is part of abdominal examination. It is said abdomen has got a back. So one must look for gibbous, spinal deformity, renal angle. There might be bulging in the renal angle. So this must be looked for. This must not be omitted. X-ray chest PA view in standing position is the ideal X-ray to look for gas under diaphragm, not X-ray abdomen. Absence of free gas under diaphragm does not rule out visceral perforation. The cause of pleural effusion is tuberculosis unless proved otherwise. When a patient is examined for acute retention of urine, the clinician must examine the patient's pupils for argyle eversion, pupils where accommodation reflex is present and light reflex is lost, and presence or absence of knee jerk, root value L234, to rule out tabes dorsalis as the cause of retention of urine. Throbbing pain, not allowing the patient to sleep, having whitlow, phelon, is an indication for incision and drainage. Blood transfusion policies. Blood and fat are said to be the biggest enemies of a surgeon. Do not transfuse the whole blood. Use blood component therapy, BCT, instead. In rapid blood loss, the tongue becomes parchment white. Single unit blood transfusion is never indicated. It is always more than 1 unit if at all required. Minimum hemoglobin level required for general anesthesia is 9 gram per cent. In any polytrauma patient, fractured cervical spine must be ruled out. Any polytrauma patient is presumed to have fractured cervical spines, and the cervical spine must be immediately immobilized. In a patient having fractured calcaneum, always look for fracture of the cervical spines, which are known as a lover's fracture. Surgery pulse continuing. In head injury patient, Hutchinson's pupil is a late sign suggestive of midbrain herniation through tentorium cerebelli due to raised intracranial pressure (ICP) by epidural hematoma, also known as extradural hematoma (EDH), subdural hematoma (SDH), compressing the third cranial nerve or oculomotor nerve indicates delay in decompressing the cranial cavity. CT scan is the gold standard investigation for a head injury patient. In head injury patient who is unconscious due to intracranial hematoma, which is a dire emergency, emergency craniotomy must be done even by a non-neurosurgeon. It is said in Oxford textbook of surgery. Pinpoint pupils, hyperpyrexia, and paraparesis or paraplegia, 3Ps, is suggestive of pinpoint pontine hemorrhage. Pretibial myxedema is seen in Graves' disease, that is hyperthyroidism. Slow release of ankle jerk is pathognomonic of hypothyroidism. In hyperthyroid patient, operate, that is, do subtotal thyroidectomy only after the patient becomes euthyroid. It is easier to manage hypothyroidism than a recurrent hyperthyroidism after operation. Middle thyroid vein is short and opens directly into the internal jugular vein. It must be securely ligated. For the diagnosis of exophthalmos, upper as well as lower limbus of the sclera must be visible. Raising of the ear lobule is the sign indicating that the swelling is arising from parotid salivary gland. In anatomical muscular triangle of the neck, the posterior border of anterior triangle of neck is formed by the posterior border of sternocleidomastoid muscle and not by the anterior border of sternocleidomastoid muscle.